All right, let's move on to our, thank you, Kristen. Let's move on to our third presenter. This presentation is entitled Meeting People at Their Door, a community-based, equity-focused approach to build vaccine confidence. And that's going to be led today by our presenter, Mara Lord. Mara, please take it away.
Thank you so much, Dr. Ruffalo. Christine, am I sharing this?
We don't see it yet.
Oh, it's not yet, not up yet.
Okay, give me one moment here. Sorry, I have slow, here we go.
It's coming, it's thinking.
There you go.
Okay, great, perfect. All right, so thank you so much, Dr. Ruffalo. Really appreciate that. I am very honored to join today as the chair of the Vaccine Integrated Communications Outreach and Community Mobilization effort across Milwaukee County. And I'm joined by our essential community partner, Lorraine Lathan, who's president of Jump at the Sun Consultants, and Dr. Ben Weston, MCW faculty member and health advisor to Milwaukee County. We would also like to acknowledge Advancing a Healthier Wisconsin, Wisconsin Department of Health Services, Greater Milwaukee Foundation, Bader Foundation, Zilber Foundation, United Way, and Milwaukee County for funding support. So in early 2021, as COVID-19 vaccine options became available, a community-wide communications and engagement strategy was developed to build vaccine confidence across our community. And that was charged to this team that I mentioned earlier, the Vaccine Integrated Communications Outreach and Community Mobilization. And we worked together with a very collaborative group across communities across Milwaukee County. We designed a community-informed approach to meet people where they are with authentic voices from our community. And in spring 2021, the vaccination data revealed that Black and Hispanic communities in particular lagged white communities in vaccination rates, illuminating the need for multiple strategies to reach individuals in socially vulnerable areas. So a community mobilizer strategy was identified to train individuals from vulnerable communities to walk neighborhoods and reach people in their homes. And a partnership between Milwaukee County, City of Milwaukee Health Department, Medical College of Wisconsin, and Jump at the Sun Consultants enabled this community-based, equity-focused approach. It was informed by the Evaluating Vulnerability and Equity model developed by Dr. Weston and led by partner Lorraine Lathan and her team. It was also supported by Nick Tomorrow at the Milwaukee Health Department, who provided a team and continues to provide a team of vaccinators to partner with community mobilizers. So I will turn this over to Ben Weston to talk about the EVE model.
All right, thanks, Mara. Very excited to be here. So early in our COVID vaccination effort, we recognized significant disparities in who was receiving the vaccine. And in response to this, we created and disseminated the EVE model. So it stands for Evaluating Vulnerability and Equity. And this model uses the CDC's Social Vulnerability Index. That's an index that categorizes census tracts by vulnerability. And we place that side by side with vaccination rates. So we're then able to create a geographic output, a map, as you see here, that highlighted our orange communities. So these are the communities that were high vulnerability coupled with low vaccination rates. And I'll pass it to Lorraine to talk a bit more about how this data was used to develop a community-based intervention.
Thank you, Ben. So in terms of our methodology, we recruited residents from those census tracts. It was important to have people from the community that had credibility in the community. So we recruited and we trained them. They went through a training. And then each day we would go out, we would provide a briefing. They would go door to door. And our largest, and all of our partners were very important, but I can't go beyond saying how important the City of Milwaukee Health Department was. They traveled with us. So we went door to door and we were able to have open, honest, non-judgmental conversations with residents in order to give them information so they can make informed decisions about getting vaccinated. If they decided to get vaccinated, they were vaccinated right on the spot. I mean, you can see in the photos a person being vaccinated, sitting down. We've done alleys, front porches, living rooms. And then after that day, at the end of the day, we would come back and debrief. And that was really important because we had to celebrate our victories and share successes as well as challenges. At the peak of our operations, we had 57 trained mobilizers. They were paid $17 an hour. And then we also had volunteers. Alverno School of Nursing were our biggest set of volunteers that went out with us. And so that's pretty much kind of the approach, was to have honest, open conversation. The feedback that we received, people appreciated us going door to door. They appreciated the convenience of being vaccinated at their homes. Now, clearly there were people who slammed the doors on our faces because they were still part of that hesitant, undecided group. We were really reaching in. We used the EVE model each and every day to figure out which census tract we would approach. And so I guess I'm gonna move on into the results. Is that okay? So the results, as I mentioned, we trained 150 mobilizers, and then we had 57 that were paid mobilizers and others were volunteers. We were able to cover 62 census tracts. There's 297 census tracts that need to be covered, at least at the beginning. Some census tracts could have as many as 7,000 residents in one census tract. So we made a little bit over 13,000 people we were able to reach. And part of those were actually having conversations with individuals, and others were leaving the door hangers. If you look at the photo in the middle that says, "Looks like we missed you," that was information where they could follow up. We also had a texting program so that when we were out in the community, people knew that we would be in those census tracts. For me, a big kind of tangible result that's difficult to measure is just the goodwill that occurred. People saw us out in the community. They realized that there are people that care about these communities and want to see people vaccinated. So with that said, I'll pass it on to Mara to talk about challenges.
Thank you, Lorraine, and thank you for all of your incredible work in the community. Just briefly to give an overview of challenges. So sustained funding was one of the greatest barriers because we were doing this work real time. And in order to sustain the work, we did need to pay for many resources and wanted to ensure that individuals, those 57 that Lorraine mentioned, were paid equitably and consistently. And so ensuring sustained funding was very critical, and we had a difficulty getting dollars in the door in a timely manner. And so that created other downstream barriers. So access to technology, as an example, sometimes access to food or water for individuals. So it had a larger effect. Lorraine mentioned vaccine hesitant households. That some of those discussions were just very difficult, challenging, and that was something that the team was constantly rethinking how to have those conversations. And then data tracking, that if there had been more consistent technology, we think data tracking may have been sustained in a different way, but again, there was a funding barrier. And then I just also want to mention just the seasonality of this, having individuals knocking on doors in communities in very cold months or rainy times is very difficult as well. And then now we'll just finish up with opportunities. Dr. Weston.
Thank you. So we see two key areas, I think, for future opportunities. So the first one, this is a model for how to get vaccine into the arms of vulnerable populations. And we've seen nationally that the areas that are historically and systematically underserved, these are often populations of color, have lower vaccination rates. And we've also seen that these communities often face barriers, both logistical barriers, but also misinformation-based barriers to vaccination. So this program helps to overcome both sets of barriers. And second, and more broadly, we hope that this intervention can expand beyond vaccination for promotion of other health behaviors in vulnerable communities. So capitalizing on the infrastructure of this program and the connections that have been fostered in these communities, this same program, this same model could be used for things like violence prevention, for substance use, and other health maintenance interventions. And I'll hand it back to Mara to close us out.
So thank you so much for this opportunity. We hope that this does follow some of these opportunities in the future. We're happy to take questions.
And before we take questions, just one quick thing I wanted to add, because I see Al Castro is on the line as well. We did have a bilingual team as well. So we were able to go out. With Alverno, we had 6 students that were all bilingual, and then we had our own bilingual team. So we were able to share this information on the South Side and get people vaccinated and share the information in their own language. So that was pretty important. And then finally, one of our other partners was the fire department. And this goes back to Dr. Weston's mention of how this model can be used. We were able to install smoke detectors in households as well as we were knocking on doors. So thank you.
Thank you for that, Lorraine and team. Wow, this is such exciting work, and double bang for your buck with putting the fire detectors in there. That's great. I think the community-based collaboration that was exhibited in this project is just outstanding, just phenomenal. The chat is full of questions for your team, and I see that Dr. Weston was starting to chip away at a few of them. In the interest of time, I'm going to direct the 3 of you to the chat to see if you can make some progress on those questions. Thank you so much for that. It was a great presentation.